Good afternoon. My name is Antonia Drew Norton, formerly Antonia Van. I recently married, and myself and Crystal Ayad and Rosalind McLean are here to talk to you all about our experiences and our work with individuals, victims of domestic violence, sexual assault, and human trafficking in the city of Milwaukee. And we are part of the ASHA project now at End Domestic Abuse Wisconsin. We were formerly called ASHA Family Services. We've been in existence since 1987. We're the state of Wisconsin's first culturally specific African-American domestic and sexual violence prevention organization in the state, and we're one of the first in the country. Our work centers on equity. It's about equity in service delivery. And that kind of goes into our talk about implicit bias, particularly with this population of African Americans in the city of Milwaukee, and with its impact in working with this population in the city of Milwaukee while navigating the COVID-19 pandemic. Again, I wanted to make sure that each of us, that you are aware, each of us will introduce ourselves. And I want to facilitate a discussion with Crystal and Rosalind about the work and how implicit bias shows up in our work and how COVID-19 impacts the community, but is actually exacerbating. So the link between COVID-19 and domestic violence, it doesn't appear obvious, but violence between intimates, partners, it is, NIH has significant data that talks about the relationship between poverty and the likelihood of violence within intimate relationships. And that centers around the social determinants of health. So when you combine COVID-19 and domestic violence with poverty, lack of access to housing, racism, discrimination, bias, and unemployment is exacerbated by the COVID-19 pandemic. Black and brown folks are disproportionately affected by the virus, facing an increased risk of becoming infected and dying, and disproportionately impacted by the side effects of the pandemic. At ASHA, we've had to navigate this pandemic while trying to keep survivors of violence safe. And significantly impacted were children who did not have the resources that were typically around them, such as being able to go to school during lockdown or during times when school was not in session. So their supports might be their educators. The social workers at the school are able to have conversations with them or be able to know that something was impacting them in the home. These children suffered in multiple ways, and that included food insecurity. For many of them, their only access to food or multiple meals in a day was to go to school. So there are a number of factors that are impacting Black and brown communities. Milwaukee's Black poverty rate, for example, of 36.4% is among the highest in the country, whereas Wisconsin's poverty rate is similar to the national level of about 7.9%. That's not so for the Black community. Domestic violence thrives during periods of economic insecurity. And the job loss because of COVID-19 and consequent increases in economic stress has resulted in increased incidents of domestic violence. As a matter of fact, what the field of violence prevention providers is experiencing is new cases of domestic violence, where prior to the pandemic, violence was not prevalent in those relationships, but they are now. One of the reasons that ASHA exists, and please forgive me, I'm kind of under the weather, got some cold or flu issues going on, so please forgive me. But one of the things that ASHA exists, the reasons ASHA exists, is because of one of the barriers faced by survivors from communities of color in accessing mainstream services. And women have reported their experiences. There's considerable data that I would be very willing to share that talks about the barriers to services experienced by women of color. And there are through some perceptions that include implicit bias and racialized discriminatory practices of programs. So because of this, ASHA exists to counter that, to mitigate the harm caused by not only the historical trauma within the communities, but also within Black and Brown survivors' access to services within the community. So it exists to provide equity in service delivery, and we've done that for over 35 years. So I would like to introduce Crystal, and then if you all were able to get Roz's phone together. Go ahead, Crystal.
Good afternoon, everyone. My name is Crystal, and I'm the lead advocate with the ASHA Project. I've been officially working for the ASHA Project since 2018, but I've been volunteering with many of the community outreach programs for quite longer than that. And it's been an honor and a pleasure to serve our people in this capacity. We see everything come through our doors, from human sex trafficking, domestic violence, sexual assault and abuse, and elder abuse. We deal with it all, and we've seen it all. Just in the short time I've worked here in my official capacity, I can say that it's very rare that we have two clients that are exactly alike. Actually, I've never had two clients be exactly alike. And one thing we strive to do is to treat every client that we get as an individual. So we don't give our clients rigid programming. We give them programming specified to their exact needs and what they have the ability to accomplish realistically. So that's why it's so important that we exist. Even though we're a smaller agency, we do a lot of big things for the people we serve. So yeah, that's it for now.
Okay, did Roz get back in?
I'm gonna check.
And in the meantime, let me ask you this, Crystal. Can you talk about instances with clients that illustrated where implicit bias or racialized bias was prevalent? And I have a second part to that, and that is, and we'll talk about that a little bit more, but I wanted it on your mind that looking at as terms of healthcare providers and the experiences of those we work with, resistant to the COVID-19 vaccines, or clients thinking about the COVID that you are aware. Can you talk about that as well? So I know that's two parts, but
Yes, ma'am. Well, I would say to that and to everyone listening that um my clients experience the most bias and racism when we have to reach outside of the ASHA project for resources that we don't currently have. So if I have a client that's in need of shelter, this is where I see it the most often. I'll call a shelter on their behalf, and it's very clear to me that there are shelter services available for them. But of course, they want to talk to the client, and I'm sitting right there. I'm either on the phone or I'm sitting right there, and the client tells me exactly what I said. And the client is also clearly in need. And oftentimes after whoever's doing their intake talks with my client, the one's available shelter spot is no longer available. And they'll always say, well, we can't tell you why. And when I probe the client, like usually it's not because they stayed there and caused an issue at some point in the past or anything like that. They're like, I've never stayed in a shelter before. I've never had any interaction with these people before. I don't know why they would reject me. And they'll never tell us why. But the thing is, you don't have to be a rocket scientist to know that there are a lot of internal biases that people have. So when people get on the phone with some of my clients and they hear them speaking, which what they used to call Ebonics, but now they call it African American Vernacular English, right? That sounds normal to me. I think nothing of it, but oftentimes they get on the phone with someone who is using that to judge them. They don't want them in the shelter because now they're making, and from what I'm seeing, and in my judgment, they're making a judgment on their character based on how they're speaking because they can't see them. So you can only hear what you hear. And oftentimes I believe they're making a judgment call thinking they're going to create issues, or maybe they want to keep shelter spots open for their own community. I'm not really sure what it is. But what is always obvious and what has been consistent, especially in the last couple of years, is that they are experiencing these unreasonable things. So that's one instance of just the biases that our clients face. Now, if we're talking about healthcare concerns, because Black women and Black men have a general distrust of white-run systems. That includes the healthcare system. We have a history with this country in which we have received healthcare and continue to receive healthcare that is not only not specialized for Black people, but have been actually harmful. We can go back to the Tuskegee experiment where they believed they were receiving treatments that they were not receiving. And the men who had syphilis were able to go out into the community and infect countless women and in turn, other men. So you had this disease running rampant in our community. This experiment was financed by the US government. Then you have situations where our bodies are being monetized after our death. You can look at Henrietta Lacks. You can look at all these instances of medical abuse. And most recently, we can look at our maternal death rates that are taking place among Black women. And you can see how we are dying at unprecedented rates when we're dying at the rates of a third world country, as if we don't have advanced healthcare to keep women alive. And oftentimes, not only are we dying, but our babies are dying before the age of 1 due to the lack of healthcare. I have personally experienced abuse at the hands of the medical system here in Milwaukee. And I know many women who have. So when we're looking at the COVID-19 pandemic and we're wondering why there's some resistance, because I can tell you, I noticed that those of us who are a little further removed or feel that we're a little further removed from, racism and things like that, we have no issues taking the vaccine. However, I noticed, I would say 90% of my clients, which is really, that's a lot, right? Don't want to take the vaccine. And I don't think that, and I cannot say that I blame them, because when you've experienced abuse and you're looking at this thing oh, you need to inject me with this thing that's completely free and I don't have to do anything except walk into a place. There are people even coming to our doors hey, you can just step out on the porch and I'll inject you, so all of this is happening and there's already resounding mistrust of the medical system in just white America in general. So, or I should say white systems that are in place by the majority. So when all of this is taking place, if you as a medical provider is saying, okay, I really believe this is in your best interest, I don't think it's ever proper to ignore the very real experience that Black people have had here of medical abuse, abuse of at every system that we turn to, that, we're just gonna, accept. So, and I understand that that some people will argue that, the vaccine resistance has made the pandemic worse or what have you. I'm not here to argue that either way. But what I will say is that there is understandable mistrust toward anything that we're getting for free. We have a hard time as a Black agency helping some of our clients just doing what we do, because they see us as extensions of the system that we're in, until they really come in and get to know us as individuals. That's why I said in the beginning, we try our best to serve each client that we get individually, as individualized as we can get it. Because when they don't feel like they're just a number coming through the door, the trust opens up. So we have an easier time getting them to safety when we're talking about domestic violence, or we have an easier time recommending them to mental health care, to medical care, wherever we need to send them.
And so they're going to trust us more.
Yes, ma'am. Absolutely.
Because of the way, I think, when we, Harvard has a brief definition of implicit bias, and it indicating that it's also known as implicit social recognition or cognition. Implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions. And we do it in an unconscious manner. And the reality is that everybody has these biases. Some where they are harmful or cause harm, those individuals have an opportunity to reflect on that. And particularly those in working in the healthcare is whose mantra is to first do no harm. One of the things that you said earlier when you were talking about maternal deaths, and I think in many instances, people don't realize the impact within communities of color. And in Milwaukee, the infant mortality rate is typically number 1, 2, or 3 nationally. That's where Milwaukee ranks in infant mortality rates annually. And this has been going on for a number of years. So when COVID-19 exacerbated this, and particularly when we have clients that are pregnant, we know we have to go far and beyond, because we know that there's a likelihood that mother will die and a greater likelihood that that baby will die. And so there's just certain things that we have to do that tie into trauma-informed practices, if you will. So, and that's historical trauma experienced living within the city of Milwaukee, as well as the trauma experienced in within intimate partner relationships. I think there's one thing that is relevant that I would share, and you will recall these experiences. At ASHA, we recently held a focus group. With survivors of near fatal domestic violence incidents. Now, what's currently going on in Milwaukee is that we're nearing 50 domestic violence homicides. Last year, the Wisconsin Coalition's in domestic abuse homicide report indicates that there were 37 homicides, and all of last year in Milwaukee, we're already up to nearing 50. And what is significant is that the city of Milwaukee is also experiencing, we're just over 700 non-fatal shootings. But what's stark and startling is the fact that there's 250 of those are women, and which is on both these categories, the numbers are unprecedented. And so one of the things that we did was to hold this focus group with near fatal domestic violence survivors. And there, just to give you an idea, one of the survivors was shot 23 times and she survived. One was shot 9 times. Another one was shot 4 times. Another one's throat was cut and she was stabbed. Another one suffered traumatic brain injuries. The number that were strangled or near beaten to death, run over by cars. So it was important for us to get an understanding from that population who just by a blessing and a prayer did not end up like the other women that experienced these, that did not survive these incidents. And we needed to learn from them what they knew, what they didn't know. One of the things that we are hearing anecdotally is that many women from particularly communities of color do not like engaging with mainstream programs, similarly to reasons of mistrust, as indicated in the examples Crystal provided. The other portion of that is at one point in the conversation with these women that we had the focus group with, is that one of them indicated that she wasn't going to tell people all her business. They just want to know all your business, as the way she put it. And then another woman said about programs, when asked, did you know of services that were available and why didn't you access those services? And one indicated that we just a number. They just want to count us. They just want to get money for us, and that's it. They're not going to do anything for us. And again, that goes back to the mistrust of the system. They talked about how they were talked to, that they talked down to them. And to go directly to a piece that Crystal said, one woman said that no, they're not gonna treat us like anything, because especially if you too black, considered too black, too ghetto, they don't want to have anything to do with you, or they'll talk to you like you got a tail on you. So these are practices. Asha came in based on our program, and structuring was based on data, based on earlier research by a number of individuals in the field that talked about the barriers. So what we're hearing and seeing is people's reluctance, these survivors' reluctance to access services, or they have an anger or resentment towards the services, which is where we come in. We help them navigate these systems. There are some places, where you got to fill out this form. We got to give them this form. But because they trust us, we're able to get a little further with them. So I think that when our approach with them is trauma informed. So we don't work with them or deal with them as if something is wrong with them. We know hurt people hurt people. And so we operate from, what happened, and listening and trying to understand and make them feel heard, making them feel seen, making them feel valued. And that's going to be a process. So one of the best ways to do that is to have ongoing discussions about this issue of how we understand this population. I'm also a faculty with Professionals Aspire, LLC, which does education and training around working with gender-based violence victims, with a focus on working with African-American victims within systems, within helping systems. So having honest conversations and saying there's a lot of things that none of us were taught about a population, about a group, about Blacks, or about the Native American populations or their contributions. And so we can have these frank discussions about that, and do so in a communicative manner, where we are open to receiving information and understanding. And so, and back to our early years where we were established, there were individuals listening to Black and Brown women talking about their need for another service that was developed by and for them, because other groups didn't understand them and didn't want to understand them, and saw them as something that was wrong with them, as opposed to understanding what was going on with them in their daily lives. There's still places in the city of Milwaukee that Blacks, for example, will not go to look at houses or consider housing in those areas because of the legacy of historical trauma and the pervasiveness of it, or the way people are talked to, or the way people are perceived, or the way people are looked over. So I think it's important, particularly with a victim population, is getting a deepened understanding of why they are the way they are, and what contributes to their resistance or perceived anger. In many instances, it's their way of having control or seeing how they act or behave as something abnormal. Similar to the example that Crystal said, that early in my years, in the late 80s, in the mid 80s, working for Task Force on Battered Women, which was the largest domestic violence program in the state at that time. And I did domestic violence restraining orders in the courthouse. I was the only Black staff at that time. And the majority of the victims, we were seeing 1,000 victims a month, and the majority of those victims were African-American women. And when these women would come in, they would be loud, they would be gesticulating, they would say, "You better get this so-and-so, SOB, whatever." They would just be, make this stop. Whereas the advocates in the courthouse saw this as threatening. It made them afraid. Me, I'm thinking, girl, I'm right with you. It did not come off as that to me. So that gave me a window into understanding and hearing what these women say or their feeling about how far someone will go to help them, or to what extent. They're not really going to help me. But this is also the same population where they were 75% of the numbers. They were also the majority of cases that did not follow through with those restraining orders. They came in for the initial restraining order, but they would not show up later on. But I had to have an understanding. So these were my first years at UWM. I was full-time UWM at the time, and trying to get an understanding of why they would not follow through with those restraining orders. And my understanding, my learning was that these were cultural issues around turning a man over to a system that hated him worse than they hated her. And so that was one of the things that you always hear. Them people they don't like us. They don't like us. They mistreat us. They talk crazy to us, or either they loud talk us and putting our business out there or requiring. So it's having a greater understanding of what is happening in their daily experiences. And by the time they do get to a doctor's office, there's no telling how many instances of racialized bias they may have experienced throughout the day. And for many, you endure that on a daily basis, and which also adds to the stress, but it also is harmful because it keeps them locked in their communities. It keeps them locked in their families, in their households, and people are dying. So I did want to, I don't know how much time we have.
It looks like we have 25 minutes left. I'm not sure if people have questions or how. I think we see it in the Q&A, right?
And please feel free to ask your questions, any thoughts that you might want to share. And also, let me just add, I'm a talker. I love talking about my work. I can't imagine doing anything other than what I do. But one of the things that I think it's important for people to understand is that because of the lack of information within communities of color, and because of the lack of health services within communities of color, that in itself presents a mistrust. So one of the things that we made efforts to do was to also educate people in the community that ER is not a primary care physician. It's just not. And that we need to be able to get people locked in with a primary care physician. They could be black, white, it doesn't matter, but have someone that you go to that has an understanding of your healthcare needs and is developing a relationship. In many instances, it is solely about relationships. This population significantly values relationship building, so they can be able to trust that healthcare provider. And for some, getting them from not treating the expensiveness of an ER, but making sure that we can identify the healthcare providers within the community and making sure that we have their information, but also for us to get an understanding of them, because I'm not going to send somebody somewhere where I know they're going to be mistreated, and or there's going to be issues. We had one here with a eyeglass place where one of the patients, overheard two nurses in the back use the N-word in reference to this patient. And so there's a number of kinds of things that occur, that continue to occur. So it's real important to try to build relationship and that means listening. That means listening to them and understanding them and using a trauma-informed lens in working with them, taking that time as opposed to rushing them through and checking them off. And sometimes you can do that. Sometimes we get bombarded and we don't have the time to devote because of the sheer numbers of individuals, but we also have to go back and do follow-up. I know that's different for healthcare providers, but at some point and place, something has to happen on the front end that creates the possibility for that. Unfortunately, in Milwaukee, a lot of healthcare, the insurance industry, for example, would not allow billing from certain zip codes in the city. And so providers moved to zip codes they could get full billing for. We get it. But at the same time, that took access to care out of poor, marginalized communities. And so there are a number of practices that are taking place that are harmful to this population. And for survivors of gender-based violence, for many of them, they really want people to ask, are you being harmed? Are you okay? And not necessarily asking them in speaking the language that that they will most likely understand. That's the same as meeting them where they're at. And I saw one phrase in a recent document where clients were asked these particular set of questions. And I thought to myself, I have clients that aren't going to know what that means. And so there's a difference between talking down to someone, but also explaining it, even saying it another way. And then even asking the question to repeat back, are you saying that this? So I can understand you. I just want to understand you. And I think when people also are honest and say, you know what, I don't understand that. And speaking with a client, I don't understand that. And being honest about that. So I think communication is important because, again, this population is thrives on communication. Did you have anything you wanted to add to that, Crystal?
I do have some thoughts, but I would like to know if anyone does have questions, because I think it would be a really good idea to be able to have some engagement and answer any questions or respond to any thoughts that people might have.
And we do have access to, we have an extensive reference on, if you want to know more, I would certainly be willing to share that with Dr. Robinson, to share with you, those that are on the call, and have additional conversations. It is helpful to us to be able to understand what is useful to you. What is useful to you to know and understand about working with populations of color and gender-based violence survivors. Even concrete conversations. I remember one provider asked the question about, understanding language used by this population. And you also have to understand that, in many instances, we're dealing with populations of, Gen Z and Gen X, where these are rising populations that came up with, and I'm a baby boomer. So we didn't have cell phones. We just had gotten TVs. So we didn't have the cell phones, and we didn't have the technology that we had. We had typewriters to do our typing on. So, but this population, these phones and the technology that they have access to, their thinking is very different. And how they see the world is very different. So it's just, it would be, just know that we are very much open to having any additional conversations about specific, areas. For some, we have, and I know we've done a lot of work in Green Bay, particularly with our sex trafficking victims, and even understanding that population. Even understanding that population of survivors and seeing them in other places. We just got called in because of Rice Lake. So Rice Lake, the police department in Rice Lake was having a number of young Black females in their jails. And the reality is that they can't stand out in Rice Lake. And they can't not. They're going to stand out in Rice Lake. And so our work with them was to naturally talk to them about why they are there. And so when there's major events that are going on, that there's going to be an increase in the trafficking of survivors. So,
Yeah, Ms. Van, Renita had a question.
okay.
And I can respond to it, or you can if you like. She says, Asha has been around through a number of social changes. How has serving victims changed with the speed of access, social media, etc.? Is it making it easier, better, or challenging? And in what ways?
It's challenging in a number of ways, but we step to it. I think it broadened our capacity, because I can tell you the number of trafficking victims or domestic violence victims that we communicate with through social media, and have had to move them across the country, either back here to Wisconsin or to get them to programs. So the social media has opened the door. We have a campaign, and it's called We Are Here MKE. So weareheremke.org is the website for the 7 culturally specific programs in the city of Milwaukee. And it's all of the programs in one place, and clicking on each one gives that individual access. And because the reality is that for many individuals, they will not access mainstream programs because they don't trust mainstream programs. And that could be based on years or generations of experiences within that family. But social media has broadened how we deal with this population. Talking about the generations, they know what they're going to access is information on their phone. They're going to vet you based on the information on their, they go to our websites, they go to our Facebook page, they go to our Instagram, they contact us through these sources, particularly through Facebook and on our website, sending us messages, asking for help, or a family member asking for help on them. We had a father call and say his daughter was taken. She was actually sold by her best friend, and sold to some guy in Illinois for a week for $100. And he brought her back. He actually brought her back. But you know, the dynamics, that's so when Crystal said no one case is the same, no one case is the same, and individuals' experiences are the same. And even with the things around social media, another dad called because his daughter was sexually assaulted on a date with someone on one of these sites that they had a date. We have a young woman, actually she's a chapter in my book, and it's called the 40th Man. And this young woman was coerced from on a dating site, and the guy came to Milwaukee. She came to Milwaukee to meet with this guy, and he took her and put her in a house, in an apartment, and she had to service men. But the 40th one is the one that knew something wasn't right, and he called police. So social media, there's the pros and cons of it, but it also provides access for anyone in the family to access support and help. And it's law enforcement's dream, because so many of these individuals will put their daily experiences out there. And law enforcement, one of our clients we were able to get a conviction. We've got a number of convictions with sex traffickers in particular. And so an example is when the girl was 14, she was saying that this individual took her to different places, including Las Vegas. to perform sex acts for monies. And one of the things that helped in that prosecution is the fact that the trafficker took pictures with her and several other women, and they were in front of the Luxor Hotel. So these were the things that corroborated what this victim was saying. So social media has actually, it has been our dream. And it's our way of letting these generations know that we exist and where help is available and where they can vet that help. Crystal, what would you say to that?
I would say, just kind of, I was really thinking about the point on social media, and it's made it both challenging and easier, because here's the thing: when our clients learn that we have, like, because when we're texting clients, sometimes that's an open door for them to text us and call us in the middle of the night, to text or call us. Sorry if you all hear, I'm actually texting a client right now. Oh, so I got things going off in the background. So there's kind of, it's harder to kind of set boundaries with those we're caring for. Like, we want, of course, ideally, we want to give our undivided attention and care for our clients, because we do understand that they need it. And I don't judge them for it. It's just sometimes it can be hard to set that boundary, like just having to tell someone like, hey, I'm in a meeting, and then they just keep going anyway, so when it's not like it was maybe 10 years ago, 15 years ago, where people called the office to reach you, and that's it. If you weren't in the office, they were not talking to you. Now it's like people are expecting answers to emails right away, answers to text right away. It's like, boom, boom, boom. I need this and I need it now. Right. But the beautiful thing is, even though that's kind of one of the drawbacks, it is also a great benefit, because you could take care of a lot of things. Like, if I'm in a meeting, I can text a client, hey, the rent check for your landlord was actually mailed out, because I can look at my email and say, yes, it was sent. Now I don't have to take additional time and say, let me call you, try to get you on the phone, let's play phone tag. So there are benefits to, having the access through social media, through because then people reach out to us, like you said, through social media, because they bet us on there. But then once you get in contact with them, then they get your cell or your work cell. So the contact between clients is between advocate and client is enhanced, even though sometimes it can have a drawback. I know Ms. Band just recently experienced that with one of my clients got a hold of her information and has been calling her 2-3 times a day, which is of course not ideal. But sometimes it happens. But there is a benefit to it, because at least you can kind of establish that relationship. And I know as you all, as health, healthcare providers, or whatever capacity you're working in,
they don't,
you may or may not want, I'm not at all expecting you all to give a patient or one of your clients a phone number so they can reach you like that. But there is benefit of having the closeness to an extent, because in that way you can really provide a service to specialize just for that person, which makes the treatment that we're in our case, we're giving treatment for, safety planning and domestic violence safety, things like that. So it's beneficial, but it's not always beneficial at every turn. But I think that it has its pros and its cons, and I think they kind of neutralize each other. So for me, it's like the ease of social media and their ease of contacting us. It's kind of like I treat it as a moral, a more neutrally moral, like, I mean, morally neutral, I should say. Like, it's just, it is what it is. Like, this is the life we live now. So I
Mhm.
just accept it for what it is.
And there's also ads where we can FaceTime with them. We can access, we don't have to. And that's one of the things that COVID-19 did a number of things. All of it wasn't bad.
No.
And so it caused us to have to reshape our work and be able to go to, for example, telehealth, that kind of, and I think that's even good in many instances for the patient or the client, as well, because they could still be home or don't have to get childcare or don't have to, you know, it makes it easier to make their appointments. But there's just the flip side to that. Social media and the technology, the phones, is perpetrators' ability to track and monitor what victims do, to be able to harass them, to be able to do a number of things with them that oftentimes is not able to be documented unless it's in written text messages. So, okay, yep, time flies.
Okay.
So again, thank you for listening to us. We hope we did provide some insight into the impact of COVID-19 in the African-American community and talk about the barriers to survivors' access to services. And that includes implicit bias and other racialized discrimination and misunderstanding about individuals. So I thank you.
Yes, thank you all so much for having us, and I hope you got something out of it.
There's a question. There's a question.
It's like Kathleen just said, thank you so much.
Okay. Thank you.
You're welcome.